everyone. Good morning, good afternoon, wherever you are. I'm in Chicago, so it's still morning for me. I am so happy to be moderating this conversation today. I just want to welcome you all here to Tigerlily's Pull Up a Seat. We will be making sense of biomarkers and clinical trials today. I will start by introducing myself and then introducing our lovely panelists. We have a very informative conversation scheduled for today. My name is Jasmine Lampkin. I'm an angel advocate with Tigerlily. I'm also a registered nurse and DNP student at Rush University Medical Center. My focus is public health and community health. I'm also a two-time triple negative breast cancer survivor. So the conversation is very near and dear to my heart. And I'm just really excited about today's conversation. We will be demystifying biomarkers and clinical trials. We are breaking down the science behind these things, addressing common fears, and making sure every person has access to clear, trustworthy information. Because understanding these tools can mean more options, more hope, and better outcomes for our communities. So thank you all so much for being here. I am hoping that this conversation will bring clarity, compassion, and confidence as we explore biomarkers that influence treatment choices. We also want to explore clinical trials, how they're created, and how each of us can play a role in shaping more inclusive research. Before we begin, I want to invite everyone to just pause and take a nice deep breath and set an intention, whether that's to learn something new, share your voice, or feel seen and supported on your journey. We're here together today to create a space rooted in learning, connection, and empowerment. I'm going to go ahead and take my deep breath. Today we have 5 agreements for this space. Number 1, monitor your airtime, make space for others, speak your truth. Your experience matters. Share from your own perspective, avoid generalizing. Lead with curiosity, not judgment. And most importantly, keep a safe space. We are here to support each other. I am going to take a moment to briefly introduce our amazing panelists. Well, allow them to introduce themselves. Then we will have an open conversation and a Q&A for the audience toward the end of today's segment. So let's get started. Again, thank you all so much for joining us for this important discussion on making sense of biomarkers and clinical trials. I would like to allow our lovely panelists to introduce themselves one at a time. We'll start with Miss Kai.
Good afternoon, everyone. I'm on the East Coast in Baltimore, so it just tipped over into afternoon for me. My name is Kai Pollard. I am a Tigerlily Foundation angel advocate. I am also a 6-year breast cancer survivor with triple negative and HER2 positive breast cancer. During my day job, what I do is I have worked in clinical trials for about 20 years. Some people don't believe me, but I am 43 years old. I also get to develop NGS diagnostics for oncology, and I've been in oncology research for 2 decades as well. I am a research geneticist by training, so a genetic scientist, not medical doctor. So that is me in a nutshell. Thank you, Jasmine.
Thank you so much, Kai. Next, we will have Megan introduce herself.
Hi, everybody. I'm Megan O'Neill. I live in Los Angeles. I am a 10-year breast cancer survivor. It's been over 10 years since my early stage diagnosis. And then it's been 5 years since I've been metastatic. Since that time, I'm also a proud angel advocate, repping my gear here. Super proud to be working with the Tigerlily Foundation. Since my metastatic diagnosis just over 5 years ago, I have been on 6 lines of treatment treatment, and 4 of those lines of treatment have been clinical trials. Clinical trials is something that I'm super passionate about. So I'm here to share my experience with you all. I'm also, I see I have my pen handy. I'm also here to learn. I feel like we have so much to learn from each other. So thank you so much for having me. I'm really looking forward to this conversation.
Thank you, Megan. I'm jealous. You're in Los Angeles. I'm sure it is much warmer there than it is in Chicago.
It is pouring here.
Next, I would like to introduce Dr. Regina Hampton. Can you introduce yourself, Dr. Hampton?
Hi, good afternoon, good morning, wherever everyone is. I'm also on the East Coast as well. So I am a breast cancer surgeon, and I am I'm just joined a new practice, which is Maryland Oncology Hematology, which is part of the U.S. Oncology Network. And I have the blessing every day to work with breast cancer survivors. Working to create survivors by doing their breast cancer surgery, doing their counseling, and just getting them through, as many of you on this call know, can be quite a challenging time. But I think we're in an exciting time where there are so many advancements, and look forward to hearing from everyone else on the panel today as well.
Wonderful. Thank you, Dr. Hampton. Last but certainly not least, Michael Osborne. Can you introduce yourself?
Yes, good morning and afternoon, everyone. As you just heard, my name is Michael Osborne. My background is in genetic counseling, so I do have several years in clinical practice as a genetic counselor. I'm located in Raleigh, North Carolina, so that clinical experience was at UNC Chapel Hill. But for the last 5 or 6 years, I've worked worked as a medical science liaison for diagnostic laboratories. So I do work for Menarini, which is the sponsor of today's talk.
Wonderful. Thank you so much. So that is our lovely, lovely panelists for today. So excited to hear from them and get their perspectives and allow them to educate us today. We're going to go ahead and move into our first segment, Spotlight on CTC testing, to explore one of the exciting advances in biomarker testing. Michael, we are thrilled to have you with us and to help us break this down. CTC testing detects cancer cells circulating in the blood. This gives doctors and patients valuable insights into how a cancer is behaving and how treatment might be working. So it's a very incredible step towards a more personalized care. Michael, I'll go ahead and turn it over to you so you can share more and teach us a little bit about CTC testing.
Great, thank you. And again, thank you for having me. I do work for a company, as I already mentioned, named Menarini, but I do want the vast majority of this presentation to hopefully be informative and to provide insights into what is meant by biomarkers, liquid biopsy, other terms that are thrown around quite a bit in the area of cancer. So very quickly, apologies. I'm going to go through each of these topics fast. So just one slide on who is Menarini, and then breaking it down and what we mean by the liquid biopsy, with a focus particularly, as you can see, on circulating tumor cells. And then I'll wrap up with a few slides on the data. Of course, we want to, whenever we're talking about new technology, we want to see the publications and the data. And then we'll talk about circulating tumor cells and biomarker expression, which again, I will dive into a little bit deeper. And I'll wrap up with possible implications of today's talk, in other words, clinical utility. And I put things you can consider discussing with your provider and highlighted consider, because again, I want, if any of this information is interesting or something that you would, that you think would be beneficial to your care or someone that you love. Everything we discussed today is a test that would need to be ordered by your provider, and it's not going to be beneficial to everyone at every step of their cancer journey. So again, please take this information and if desired, discuss with your provider. Again, very quickly, just who is Menarini? And I only showed this because Menarini is relatively new to this space, but the technology is not. So I'm only going to allude to the technology one time, or excuse me, the brand name of the technology one time on this slide. So the name of the test for circulating tumor cells is Cell Search. And Menarini, the reason that there might not be the brand recognition, if you will, is that it wasn't until very recently when Menarini actually purchased the cell search technology from Janssen and then started offering the testing in 2022 after that transition was complete. But as you can see, we did the cell search technology did receive FDA clearance for in 2004, so a little over 20 years ago. So what is meant by the liquid biopsy? Let's start breaking down some of these science terms. And again, in particular, I'm going to be focusing on circulating tumor cells, or CTCs. So a liquid biopsy, as probably everyone on this call knows, just high level means that it is a way to interrogate or look at a patient's cancer through a blood draw, hence the liquid part, peripheral blood being the liquid. So there are many different ways to do liquid biopsy testing, but high level, if we look at this illustration here, pretend that this is a cancer, a tumor cell, or a cluster of cells. In this example, it could be breast cancer. And information or contents from that primary tumor do end up in the bloodstream. Again, that is what allows us, that biological phenomenon is what allows for the development of liquid biopsy products. But high level, a tumor will actually release those contents into the blood in two different ways. And one is through something called circulating tumor cells, where entire intact cells actually slough off of the primary tumor and end up in the bloodstream. So you can see that, again, they are intact. These red dots are the nucleus where the DNA is contained. And so that is, again, what is meant by a circulating tumor cell. And that's what I'll be focusing on primarily for our talk today, is technology that will allow for the detection and investigation of those circulating tumor cells. But liquid biopsy can also refer to what's called cell-free DNA or cell-free RNA. And so this is a process where instead of the tumor sloughing off an intact cell, the body actually will, attack, for lack of a better word, that primary tumor. And it'll undergo a necrotic process, meaning that the cell itself dies. And when that happens, the dead cancer cell releases its contents into the bloodstream, which includes the genetic components. So when a cell undergoes that necrotic process, releasing its genetic information directly into the bloodstream, it's called cell-free DNA or cell-free RNA. And most of the tests that are on the market right now, whether in clinical trials or commercially available, are leveraging cell-free DNA, cell-free RNA, which again is the fragmented components that are outside of the cell. Both of these are valuable tests that can provide some overlapping information, some different information, and I believe some of our other panelists are going to talk about the cell-free DNA RNA component in more detail. So as a final reminder for my talk today, I'm going to be talking about circulating tumor cells specifically. High level, the way that the technology works, it is validated and FDA cleared for metastatic breast cancer, but it is also available for use in many other cancer types, and essentially any cancer that is considered a carcinoma, which in adults accounts for 80 to 90% of all cancers. So a carcinoma just means that a cancer is derived from what's called epithelial cells. And so the way that the technology works is that there's actually almost a magnetic capture that targets a particular marker on the cell surface that indicates that a cell is again is epithelial derived. So again, indicating that it could be a carcinoma. Once the magnetic field has been applied, pulling out all of those all of those cells that are identified as epithelial in origin, then there's several different stains that are applied that provide further clarification on whether or not we're looking at a tumor cell. Most importantly, we apply different stains for what's known as cytokeratin, which is plays a structural role in the cell. But we know that in cancer cells, it is overexpressed. Certain combinations are overexpressed. So this is how we're able to capture tumor cells and then identify that they actually, how we're able to capture epithelial cells and then identify that they are actually from a tumor. Once we have completed this technology, where the laboratory is actually able to further characterize these and even quantify or enumerate them, meaning that we're able to count how many of these circulating tumor cells are present in patients' blood. So a couple of reasons why that is important, that ability to enumerate and count, track over time, is that we do know that throughout a patient's cancer journey, they'll be initiating different treatments, they'll most likely have a response, and then inevitably there'll be relapse followed by another treatment. And so by performing circulating tumor cell testing serially, every few months or as would be recommended based on your individual patient provider conversation, we're able to track the number of those CTCs and look for early signs of relapse. And I want to point out that especially for a cancer like breast cancer, you'll see that the biggest benefit, so the likelihood of actually finding a circulating tumor cell is going to be in later stage cancers. So I want to point that out because there is talk about leveraging liquid biopsy for cancer screening or at stage 1 cancers. And those platforms are validated a little bit differently usually. So if we think about, again, circulating tumor cells, it can be used at any stage, but just again, know that the most likely a patient is to get an informative result is going to be in later advanced stages. So what does some of the data look like? I'll start with the prognostic information that can be derived. So this is looking at the prognostication information that was submitted for FDA clearance and looking at the CTC counts and how they translate to a more favorable or unfavorable prognosis. And so if we focus specifically on this column, which again is the metastatic breast cancer column, you'll see that those individuals at baseline that had 4 CTCs or less were found to have a more favorable prognosis in terms of overall survival and progression-free survival, whereas the presence of 5 or more CTCs was found to have typically a shorter overall survival in PFS. I do also want to point out that sometimes, as I alluded to in this slide, there will not be CTCs present in the patient's bloodstream. Sometimes that can be because it's a very early stage where, again, we wouldn't expect many to be present. But sometimes it can actually mean that the patient has responded very beautifully to therapy. And we've seen a clearance, at least a temporary clearance, of the patient's CTCs in bloodstream. So a 0 CTC result, we do consider prognostically favorable. And in other words, indicating not only favorable prognosis at baseline, but potentially indicating a favorable response to a particular treatment. On this slide, I mentioned earlier that typically CTCs do also appear in the bloodstream prior to something on imaging. And what we're really showing here is that, again, using that cutoff of 5 CTCs, if there was discrepancy between radiologic findings and CTC count, we found that the CTC test actually did more accurately predict patient prognosis than relying just on clinical radiology. And patients with the most favorable outcome had, of course, not only negative imaging, but also less than 5 CTCs, as we mentioned. I'll stop there really quick and see if there's any questions I should address that came up in the chat. And if not, I will.
Any questions in the chat as of yet?
Okay, great. Then I will finish with my last couple of slides. So I did also mention that with circulating tumor cells, we have recently developed the ability to look at biomarkers on the cell surface of those intact cells. And so when I'm talking about biomarkers, think things like HER2, ER positive, and the way, the biomarker in particular that I want to focus on is HER2, given that it does play such a critical role in breast cancer prognoses and also breast cancer treatment. Now, HER2 typically is derived through it or assessed through a tissue biopsy and then applying different what's called IHC stains, as I'm sure all of you know. Information regarding HER2 can also be derived from cell-free DNA, cell-free RNA, the other type of liquid biopsy test that I mentioned. But the reason I believe that biomarker expression of HER2 with CTCs is so informative is that, again, since we have an intact cell, we're able to look on the cell surface directly for the HER2 expression. So if you think back to the pictures I showed of those different dyes, when HER2 is and I'll just go back to this image here. When HER2 is requested, we can actually apply an additional HER2 antibody stain. And based on the brightness of that stain can actually determine if a patient has, if that patient's circulating tumor cell has an IHC equivalent score of +1, +2, or +3, which, as you all know, in the HER2 setting has pretty profound ramifications for treatment and prognostics as well, treatment eligibility for anti-HER2 and prognostics. When we think about HER2 as well, we do know that as patients do proceed with different treatments, that the tumor can evolve. And so a patient that was initially HER2 negative later on after treatments could become positive. Vice versa is also true. And so what we have found is that in some cases, not all, patients are being treated based on a HER2 status that is much older and might not reflect the changing tumor dynamics or changing HER2 status. So we understand that tumor biopsies can be invasive, can be difficult to achieve, especially if a patient is having response to therapy. So by offering the ability to perform essentially a liquid IHC through peripheral blood, we hope that this provides a more global landscape of the HER2 status within that patient's entire body, and also can look for conversions such as this. For the sake of time, I'll wrap up here. I'm happy to answer any additional questions, comments.
Thank you so much, Michael. That was very informative. I don't see any questions in the chat as of yet, but I will keep checking. However, I do have a question for you. How is Menarini working with clinicians, patients, and advocates to ensure this testing is accessible and inclusive?
Great question. So I will mention, or I'll reiterate that Menarini did not acquire the cell search technology until 2016. So many of those clinical trials occurred, before Menarini had control. But moving forward, One of the things that we are doing um, with clinical trial enrollment specifically is, historically, many of these clinical trials have launched at large academic centers where there can be, access issues just innately. So we've really tried to incorporate community centers, community treatment centers, which will hopefully broaden access in rural populations or underserved populations. And then as we also look to the future, one of the things that I've learned at prior roles is the importance of working with advocacy groups like this one for recruitment, as well as local community leaders. It is one thing to have a lofty, important goal of having a clinical trial that is reflective of US demographics. But very understandably, there can be issues of trust with the medical community in some of those historically underserved populations. So, again, by working with advocacy groups that already have that rapport, or community leaders that already have that rapport, that is another way where we're hoping to increase participation.
Wonderful. I was actually a part of a campaign, I believe, that Minorini did. This was a couple years ago. And I was able to just share a lot of information via social media. And I got a lot of feedback. A lot of people hadn't, heard about it. And it's just opportunities like that where people, they can connect a little more with advocates and other patients. So just kind of leveraging that to kind of get the word out there is very important.
Yes, and again, thank you for the opportunity to start that today.
Of course. I'm sorry if you all heard my phone ringing. I have another question for you, Michael. Um, what excites you most about the future of CTC testing and precision medicine?
So I think that what excites me the most is the idea of further advancements with precision medicine. So with liquid biopsy and CTCs, we have the ability to again look specifically at what is driving a patient's cancer. We used to think of it as everybody had breast cancer, and then we subdivided the triple negative and HER2 positive, and now we're even looking at individual genes, which informs treatment paths, even the step at which those treatments are administered. So I do think a lot because of where circulating tumor cells are currently ordered in more advanced cases. I think a lot about the opportunity to give people more time and quality time with their loved ones. And obviously, there are other ways to leverage liquid biopsy in again early stage cancers, and hopefully that also means that using other platforms or other liquid biopsy tests that we can improve outcomes, increase overall survival, and rates of remission for those early stage cases. I also think that personalized medicine has the opportunity, emphasis on quality of life, to potentially um, identify treatments that will have the fewest amount of side effects or combinations of treatments that have the fewest side effects. So again, that the time that patient has is quality time with loved ones, friends, family.
Absolutely. Thank you so much for that. We do have a question in the chat for you, Michael. We have a guest joining us all the way from Canada, and they are asking, is Menarini cell search available in Canada?
That is a fantastic question. Um, I would be happy to find that out and report back if there's a way for somebody on the panel to get that um, contact information.
Absolutely. Thank you so much. That was a very informative um, presentation. I thoroughly enjoy pictures personally. So thank you so much for showing us the breakdown and everything and showing us visuals. I really appreciate that. And I'm sure our guests appreciated that as well. It is now time for us to head on over into our second segment, clinician perspective, understanding biomarkers, where Dr. Regina Hampton will answer some questions for us. Again, thank you so much, Michael, for that great overview of CTC testing. Next, we'll hear from Dr. Hampton in our clinician perspective. She'll be answering questions about how biomarkers guide treatment and what patients need to know when talking with their healthcare providers. So let's go ahead and dive in. Dr. Hampton, we are so excited. First question for you, how do you explain biomarkers to patients and families in a clear, approachable term, and why does that matter?
As you'll see from the slides that I have, biomarkers can be quite confusing. And even us as physicians, I think one of the problems is the language that we use around biomarkers can be quite confusing. So you can see here, just as you all as patients are a little confused about which terminology do we use, we're also confused. And this is really emerging technology, which is really exciting. Next slide. So let's start out with some of the terms. So biomarkers is really just a big category where we're looking at genes and proteins of the cancer cells. Then there's something called genomic markers or genomic testing. And that's where we can look at genes in the cells. And what we're trying to do is really predict the behavior of the tumor. Not as easy as it sounds, but we're trying to get there. And then, of course, we're all familiar with genetic markers and genetic testing, where we're looking at the genes, not only of the tumor, but of individuals, where we can try to determine who may have inherited disease. We can determine, what the disease process is going to do. Everyone's familiar with BRCA1, BRCA2. Those are two of the most studied genetic markers where we know if someone has BRCA1 or 2, they're going to get breast cancer. They're at about a 90% risk for getting breast cancer, a 65% risk for getting a second breast cancer, and about a 45% risk for ovarian cancer. So that information is valuable because that can help not only guide treatment, but we can help use it for risk reduction as well. Next slide. So we run tumor markers on all tumors. So we run the estrogen receptor, and that's rated, you'll see on your pathology report, from 0 to 100%. There's the progesterone receptor, and that's rated from 0 to 100%. And what essentially these are, I call them little grabber sites that are on the surface of the tumor cell that allow the cell to bring in estrogen and progesterone into the cell. And many cells can use these estrogen and progesterone that we all have in our bodies all the time. It can use our own hormones as their food to grow and to multiply. And so, as we know, there are medications that can be used to help block those receptors. So once someone's treated with breast cancer, we can block those receptors so that if a tumor cell decides to form in the future, we can try and block that process from happening and try and lower that risk of that tumor coming back in the future. There is a third item that you'll see on your pathology report, and that's called the HER2-neu. HER2-neu is not necessarily a grabber on the cell surface, but it is associated with the cancer cell. And usually you'll see the rating on the report of a 1+, a 2+, or a 3+. 1+ is what we call completely negative. 3+ is what we call positive for HER2 expression. And so those patients are going to get a medication called Herceptin, and I'll go to that in just a moment. And then there's the HER2, what we call equivocal. It's kind of middle of the road. It's not really negative. It's not really positive. And then we as the clinicians are like, well, what do we do now? So the next thing we'll do is run a second confirmatory test called a FISH. And it's either going to be amplified, which means it's truly positive, or it's going to be non-amplified and mean that it's actually negative. When the HER2 is positive, those patients are going to get, in addition to any other treatments that they get, a medication called Herceptin. And what it is it's a laser focused medication that goes, it's almost like a video game. It goes and finds those cells that have the HER2 positive expression and literally destroys them. And medications like Herceptin have really been a game changer because a HER2 positive tumor can be considered a more aggressive tumor. But because the treatments are so great now, we can really control HER2 positive tumors a lot better than we could in the past. Next slide. So then we look at genomic tests, and these are something that have come out probably over the last 20 years or so that really help us to get more information. Yes, we know the ER. Yes, we know the PR. Yes, we know the HER2 status. But what does that mean? We know that there's additional information in the cells that we can't get on a pathology report, that we can use that information to help guide treatment. So 3 of the big tests, MammaPrint, Oncotype DX, and Decision RT are 3 tests. I'm going to walk you through those. Next slide. So the first test I'll walk you through is something called a MammaPrint. And what the MammaPrint does is it looks at 150 different genes in the tumor cell to try and get information on, is this a high-risk tumor? Is this a low-risk tumor? The nice thing about MammaPrint compared to some of the other tests are that this can be run on all tumor types, whether you're estrogen positive or negative, progesterone positive or negative. Even if you're HER2 positive, you can get the MammaPrint test done. It's run ideally on the biopsy specimen, which then means we can get that information very early on before we even start treatment to help us to guide treatment. Should it be surgery first? Should it be chemotherapy first, something known as neoadjuvant chemotherapy? We can get all this information, and that really helps us to design the treatment plan for that patient. You heard Michael talk about personalized care, and so it's these genomic tests that really help us to really personalize the care. The other thing this test can tell us is, will the patient benefit from extended hormone therapy? Most people will get hormone therapy for about 5 years, but there's some people who would benefit 10 years. And so this test will give us that information so that the oncologist can have a conversation with the patient. Next slide. So then there's a test called an Oncotype DX, kind of similar to a MammaPrint. This runs on 21 genes, and this was one of the first tests that was available. One of the limitations when you compare this with the MammaPrint is that it only can be run on tumors that are ER positive or PR positive. It has to have that progesterone or estrogen receptor in order to run this test. The other cool thing about this test is that you can run it when someone has positive lymph nodes, up to 4 positive lymph nodes. This can help to give us information. And what this test tells us is, does the patient need chemotherapy or not? So the higher the score ranges from 0 to 100. The higher the score, the more likely that you are going to get a benefit from chemotherapy and that you are going to get a reduced risk of recurrence over the next 9 to 10 years. So if we know that today and we can try and say, hey, in the next 10 years, you have a high risk of recurrence, chemotherapy is going to be advantageous for you, then that is a lot of great information that you know. On the flip side, if you have a lower score, this will tell us that you have a tumor that is probably has a lower likelihood to recur in the future. So then we may not give you chemotherapy. We would opt to do, hormone therapy in addition to any surgery and or radiation. Next slide. And then the last test I'll review is something called the Decision RT. This is only for DCIS patients. And, there's been a lot of talk in the literature about DCIS. Is DCIS really a cancer? Is it an early cancer? Is it a precancer? Again, us as clinicians are still kind of debating this. And there's a lot of emerging data that's coming out daily about DCIS. And so the big question is Well, if it's so early and it's usually stage 0, do these patients need radiation? Are they going to benefit from it? Just like we want to know, is somebody who has an invasive cancer going to benefit from chemotherapy? So we can run this test, and this test will give an answer to determine if the patient will benefit from radiation, and radiation is used to help lower the risk of that cancer coming back locally in the breast. Or they get no benefit, which then means these patients can forego radiation, and then be followed, usually with their hormone therapy, getting their mammograms, and just be followed that way. And then that just eliminates that risk of radiation, which does come with some risk, but radiation also does a lot of good. Next slide. So the goals of these types of tests, and hopefully there are new things emerging, it really gives us more insight into the tumor biology compared to just looking at the estrogen, progesterone, and the HER2 status. And this really guides us into more precise, individualized care. And the result is patients have better outcomes, and we know how to monitor these patients in the future. Are these patients that we need to keep a hawk eye on because they're at higher risk for recurrence because of the results of these tests? Or are these patients who show that these tests show lower numbers? And yes, we are still going to follow you, but we know that your risk of recurrence is going to be low. So it's really exciting and emerging. I hope there will be more of these type of tests that come out, just to give us more information and insight so that not only can we do better as clinicians, we can provide better care to you all as patients.
Thank you so much, Dr. Hampton. That was very informative. It can be difficult as a patient to read your biopsy results and understand everything it's saying, and it's really hard to not go on Dr. Google. Um, so I just appreciate you just kind of breaking it down for us so we can really understand what we are looking at when we're reading these reports. I do have a couple of questions for you, Dr. Hampton. What steps are being taken to make biomarker testing more accessible, affordable, and understandable for patients?
Yeah, so the basic biomarkers, estrogen, progesterone, and the HER2 are standard. And, I would encourage everyone to look at your pathology report now that medical records are so accessible. Go over these results with your physician. If they have not given you this information, then there's some pieces missing to the puzzle and you need those answers, because that really is going to guide treatment. It really just takes a lot of time trying to just explain, all of these complex terms to our patients so that they can understand, because it really is important for them to have that understanding so that they can then understand why we're recommending certain treatments uh, versus not.
Got it. Thank you. We do have a question in the chat for you, Dr. Hampton. What does FISH and DCIS stand for?
Yeah, so DCIS stands for ductal carcinoma in situ, and that is what's known as a stage 0 breast cancer. Usually, these cells are still within the duct of the in the breast, versus an invasive cancer, same cells, but the cells have started to grow through the lining of the duct. FISH, and I'm probably going to mess up the name, but it's a fluorescent in situ hybridization. I think I got it right. That's terrible. But essentially, it's a confirmatory test when you get that HER2 result, especially if it's a HER2 2 plus, to tell us whether the HER2 is actually expressed. So then you want to give those patients Herceptin. Or if the HER2 is not expressed, you certainly don't want to give Herceptin to anyone if they don't need it. What's really interesting is that I think the ranges for HER2 is kind of changing. What we're realizing is there are some patients who might have a lower HER2 that still would benefit from Herceptin. It's interesting. We just had a patient that we presented at our tumor board, and that was the case. We thought she was HER2 negative. She started to recur. We re-looked at the fish. The oncologist said, "Hey, I'm going to try her on Herceptin," and she actually responded, and her HER2 was at a 1 plus. So I think there's going to be some really new emerging data as we start to look at this, because we certainly want people to get the benefit of treatment if they're going to benefit from them. And certainly if they're not going to benefit, we want to forego that, because we all know the side effects and other after effects that can come from these treatments.
Thank you, Dr. Hampton.
And if I could one comment, historically HER2 was just classified as positive or negative. And very recently, there's been this subdivision, which I alluded to a little bit, but ran out of time, where, as you just mentioned, Dr. Hampton, we realized that patients who historically fell into the negative category actually do have low levels of HER2 that are expressed. Um, Hence the potential importance of doing a biomarker expression assessment, if not through CTCs like I mentioned, but through repeat biopsy. Because again, a patient who 3-4 years ago was HER2 negative might actually be a HER2 low under the new classification and could have tremendous benefit from some of these anti-HER2 targets, like in HER2.
Absolutely.
Thank you so much. You did a great job telling us what FISH stands for, by the way. Um, Due to the interest of time, I am going to go ahead and move on to our next segment, where we will hear from my pink sisters. We're going to talk about biomarkers and the patient experience specifically. Thank you again, Dr. Hampton, for sharing your insights on biomarker testing. Next, we're going to shift over to our panel discussion, patient experience, biomarkers in action. Kai and Megan, we're so glad to have you. It's very important to hear from patients and their experience. So thank you guys so much for being here. The first question I'm going to ask is for you, Kai. How did you first learn about biomarker testing, and how was it incorporated into your treatment plan?
I actually love this question because I was working in Hopkins Oncology for about 10 years before I was diagnosed. And I ran a lab where clinical trials for Herceptin were going through my lab. And when I was diagnosed, we found out by the time I found my cancer, and I found it myself, I always try to tell people that the day after I found my lump, I went to my OBGYN. She laid me back and she's like, "I don't feel anything." And I'm like, "You know what? When you laid me in this position, I don't either." And I sat up and put her finger on my lump. It was a 4 centimeter tumor. Okay. So women, please do your own exams. You know your body. Okay. So I ended up having 4 tumors, and my biggest tumor tested triple negative. And triple negative simply means the absence of positivity for progesterone and estrogen and the so it's actually an absence of those three. It's right now, I think they need to define better what triple negative breast cancer is and not what it's not. And then I also had tumors that were closer to my armpit that tested HER2 positive. So I actually ended up on Herceptin, a drug that went through my lab years and years earlier in clinical trials. So it was just amazing to me that I got to be a part of the science that potentially saved my life. So I was treated fully for triple negative first, and then I went on to the HER2 positive therapy with Herceptin and Perjeta, and I also had Taxol thrown in there for good measure because combo therapy is our jam these days, right?
Yes, thank you. I think you have a unique perspective, seeing as though you had triple negative and HER2 positive. So you bring a wealth of information to the community. So thank you so much for sharing, and not being afraid to be vulnerable and just share all of your experiences. Um, Megan, this question is for you. What did you discover about biomarker testing that shaped your cancer journey?
Yeah, I mean, biomarker testing, it is everything for a patient, right? It's determining what is your best line of treatment. Like for me personally, just recently, I had a liver biopsy and I went from triple positive disease to all of a sudden I'm HER2 negative, progesterone negative, and still estrogen positive. So that, that helps me understand why I'm having progression in the liver. So it helps determine what treatments are best. Maybe it helps understand why is a treatment no longer working. And also, it was a simple, like these blood tests are amazing. It was the specific test from my first diagnosis to my second. I had a pain that I noticed, and I got a CT test, nothing showed up. But 4 months later, in a blood test, specifically, it was a CA 2729 tumor marker test. That's what showed my recurrence first, like test wise, like my pain, and then the scan didn't show, and then the blood work, and then the scan followed up with that. So I just think people having access to these, the knowledge of the biomarkers, the access to these tests, especially the less invasive ones, there's so much hope there. And I really, these biomarkers are really sort of determining even mutations that I have. So I have like the PIK3CA mutation that I found out I had through some genomic, tumor marker tests. And so, I haven't really utilized any PIK3CA mutation type drugs, but that might be something on the horizon that I can use as like a targeted medication. So it's everything, and really being informed about what they are. And as Dr. Hampton said, it's such a broad topic, and it's so, it's hard for us to understand and just for us to verbalize. So that's why I still have my pen in hand. We have so much to learn, and it's just really exciting.
Thank you so much. I love what you said about it just being a blood test. Because as a patient going through so many tests, images, pricks, surgeries, it's like I'm getting my blood drawn every week anyway. You just might as well go ahead and, throw that in there. I am going to go ahead and ask you another question, Kai. What advice would you share with patients who want to better understand biomarkers and their role in treatment?
It's a really good question because it's like biomarkers are very, very complicated, right? What I actually ended up going to get my master's in individualized genomics and health after I was declared cancer free because I realized how much my community needed that information. There was a lot of advocating for myself I had to do through my treatment as well. So I think the best way to understand biomarkers is one, when you hear a biomarker you have a question about, write it down, right? Like, like Danita was asking a question about fish. Write that down. Do a little research in Google and then see if you can reach out to an expert. I think Tigerlily does a great job of trying to bring this education in a very digestible way to the community. I think ask your care team the questions whenever you can. And then also, and just ask the question, right? Because sometimes you never know when someone can give you a piece of the puzzle to understanding. It might not, you might go ask, say, Dr. Hampton, and she might say it in ways you're like, I didn't quite digest that. But then you go and ask a Megan, and, between Megan and Dr. Hampton, you're like, oh my God, okay, that makes sense. It is very complicated. Give yourself grace for not understanding. And just keep Googling. I like to look at pictures. Sometimes I Google image some of these things just to even though I'm in the genetics field, sometimes just seeing that picture, I'm like, okay, that makes so much more sense. Don't feel bad for not understanding, right? And just keep asking questions.
That is so good. Give yourself grace. I am currently trying to practice that more in my life. So, thank you for the reminder. It's a lot. It's a lot of information. Treatment can be very daunting, and especially if things are changing, like you said, Megan, your biomarkers switched, and you had to switch treatment plans. I mean, that can just be very confusing. And for some reason, we are not all comfortable with asking questions and prying. So I appreciate you just kind of drilling that in, like ask the question, ask the question, write it down. Um, yeah, so we can have this information and continue to share.
Yeah, I just to add on to that, I think when you say ask all the questions for sure, but also I think just a simple question if you don't want to be too direct is like, what biomarkers have you tested me for? I think sometimes, our doctors don't always communicate exactly everything that they've done, and then a follow-up could be like, oh, why did you do this test? Like why was this the option that you went for? Because there are a lot of tests out there, as Dr. Hampton went over, and different CTC testing and all of that. So really understanding like, why did you choose that one for me? And then if there's something that you like CTC testing, I'm bringing that with me to my next appointment. Like, have we done that yet? And if we haven't, like, why not? And should we consider that? That's just a way to kind of ease it into the conversation, I think.
Yeah, I just want to make a comment. I think it is so important that you have a treatment team that takes the time to answer questions. I mean, guys, you can fire your doctor just like you can fire your plumber or anyone else. And sometimes you have to. And sometimes you need to maybe change over, as Jasmine was saying, just to hear it a different way. I know sometimes I've sent patients to say, hey, why don't you go see my colleague across town? Maybe you'll just hear it a little differently. And I don't take any offense to it. I'm like, whatever it takes for you to get the information that you need, feel free to do that.
That is so good. And that's important, Dr. Hampton. Like if just kind of meeting your patients where they are and personally taking a step back and saying, you know what, hey, you're not understanding it the way that I'm explaining it. Let me loop in somebody else. I mean, there's so many different providers. We think of healthcare provision as just doctors and nurses. We have healthcare navigators, we have advocates, we have social workers. There's so many people that are trained to help us break down this information and understand it. So it's just important to know that, the support is out there. We just, we have to take the step and ask the questions. Okay, so, whoo, that was so good. Um, we're going to go ahead and move on to segment 4, accessing and understanding clinical trials and biomarker testing. In this segment, all of the panelists will be here together, and we're just going to kind of have a discussion together and try to discuss how to find clinical trials and what to know before joining, and how biomarker testing can guide treatment. Clinical trials are research studies that test new drugs, treatments, or medical procedures. Participation is always voluntary, and trials are critical to improving care. Tigerlily's clinical trials initiatives work to ensure women of color understand and access clinical trials. So, Dr. Hampton, we're going to begin with you. I have a question for you. How did biomarker test results influence standard treatment options for patients?
Yeah, so, depending on the biomarker and whether it's positive or negative is really going to help to guide and dictate what type of treatment. So we know, I saw someone mention triple negative. So triple negative patients are usually going to be estrogen negative or 0, progesterone 0, HER2 typically 0 or 1 in most cases. And so we know those patients need chemotherapy, whether we give it to them before surgery or give it to them after surgery. They are going to need chemotherapy versus some patients that are estrogen and or progesterone positive that will make a difference. And then that's where the genomic test can help to guide us to say, hey, this patient, in addition to her hormone therapy, is going to need chemotherapy as well, or this patient will be fine with hormonal therapy as their medical treatment. And then we've talked just before about HER2 and how important that is.
Absolutely. Thank you so much. I have a question for our panelists, either Kai or Megan. How can patients find reliable information about available trials? So, of course, we have Tigerlily's wonderful platform. Um, what other ways can patients kind of find this information? I'll allow Kai to go ahead and answer
Okay,
that.
now I was going to say, I think this would be a great one for Megan because she has actually navigated this independent of the healthcare system. Like for me, I've worked in that space. So I think her answer would be honestly really beneficial for our audience today.
So the worst place to look them up is also where they all are, which is like clinicaltrials.gov. It's very, we're all laughing because we're like, if you've been on it, it's not very patient friendly. You can go through Tigerlily Foundation. I know there's some specific trial searches for the metastatic community as well. So there's different trial search databases, but they're all kind of pulling from clinicaltrials.gov, right? Clinicaltrials.gov. Okay, thank you. But in addition, I would say, so I'm a patient at UCLA, and I feel like my team is really good and knows a lot about the trials that are happening there. And they are pretty good about the trials that are happening and being pretty successful elsewhere. But you can only keep so much in your brain. So, it's really up to me as a patient to kind of dip my foot into City of Hope or to Cedars here in LA or USC and to really sort of research things on my own. And so the more educated that you are, like I'm really excited about CAR T cell therapy. I can go on clinicaltrials.gov and just type in CAR T cell therapy and metastatic breast cancer and see what's going on. But yeah, it's a really complex and an issue, honestly, of converting that clinicaltrial.gov site to really for patients to really understand what they're eligible for and if they meet that eligibility criteria.
Thank you so much, Megan. Yeah, I worked with an organization in Chicago, and they gave me a bunch of flyers, and I literally read through them and made suggestions on how to make it more patient friendly. Like switch this word for this word, or you know what I mean? Because, healthcare providers, we're so used to like that healthcare terminology. Sometimes we kind of forget that patients can't can't understand exactly what we're saying. So that's very important. Thank you so much for sharing that. The next question I have is for Michael. How does CTC testing fit into clinical trial research, and what role could it play in advancing equity in precision medicine?
Thank you. So I already mentioned, the efforts at clinical trial initiation for increasing outreach to underrepresented minority populations. So in thinking about, how CTCs and even other liquid biopsy panels are being used in clinical trials, ultimately, what I'll say what many physicians are looking for is something called phase 3 data or phase 3 trials. And what that means is physicians want to see that switching a patient's treatment, modifying a patient's treatment due to information they got from the CTC test, as an example, improves their outcomes. So either they're in remission longer, we look at metrics like overall survival, that, more patients that adjusted therapy based on CTC results were still alive at the 1 year, 2 year, 5 year mark. So we do have that some of that data emerging now, again showing that with leveraging CTCs and intervening with HER2 does improve outcomes. Um, which again, that really helps with some of the downstream accessibility issues, such as, once we have phase 3 data, a lot of times big national guidelines, like many of you have probably heard of National Comprehensive Cancer Network or NCCN, they'll look for that kind of data. And once it's in the guidelines, there's just vast recognition across the country and even world on how that can be implemented. So that's really, I think, high level, the big way that we see CTCs being leveraged today.
Thank you so much, Michael. Um, this, I just want to just pause and say thank you again, everyone, for being here. You guys are being very active in the chat, so please continue to ask your questions. We will do our best to answer them. And thank you again to our lovely panelists for being here. We are going to move on to our next segment, addressing equity and bias in medicine, where our panelists and Dr. Hampton will discuss how systemic inequities and unconscious biases can affect care and what patients and advocates can do to ensure fair, personalized treatment. After their discussion, we will open the floor to audience questions. So please start thinking about what you'd like to ask our panel. And even if you want to ask questions about what we talked about earlier, feel free to drop it in the chat and we'll do our best to answer those questions. So, Dr. Hampton, I have a few questions for you. What protections are in place to ensure patients can safely participate in clinical trials, like informed consent, research compliance, etc.?
Yeah, so clinical trials at one time, it was sort of a kind of behind closed doors. People were put in trials and didn't know that they were put in trials. And so we all know the historical experiments that were run primarily in communities of color. And while that was a bad thing, I think it did help to bring about change in the clinical trials arena, where now you have to have informed consent, and that's even kind of leaned over into informed consent for surgery, informed consent for just about anything that we do in medicine. So, we have evolved. So there's informed consent, and the informed consent has to be explained to you. What is the research about? What are the potential benefits? What are the risks to the trial? I think one of the important things to know about clinical trials is you as the patient have the right to withdraw at any time. If you feel like it's just not what you thought it was, you can withdraw at any time. But I think it is so important, as we talk about inequities, I think it's so important that communities of color really try and do their best to get involved in clinical trials. I think a great way to get people involved is like registry trials, where you don't have to take a medicine. You're just being followed over a long period of time. I'm actually in a registry trial for mammograms, the Wisdom study, where I'm not taking any medicine. I'm just getting my mammogram every year like I'm supposed to. I go onto a portal, I report my results, upload my results, and then they'll contact me every year. The nice thing is they'll remind me every year when I'm due for a mammogram. And so I think that can be a way to be a part of a trial without taking medication. I think for medical trials, I think, again, so important to just speak to your provider, your team, to see if you are eligible, because as we said, the clinicaltrials.gov site is it's good information, but it's a little hard to get through even for me. So yeah, I think we've had a bad history, but because of that history, there have been a lot of changes made.
Yes, thank you so much. Informed consent is very important. And Dr. Hampton, I just want to commend you for being a part of research yourself. I mean, that's important too. You can share like with your patients. This is a scary thing, especially for people of color. But as a provider saying, hey, I am personally doing this because it is so important to advance care. And that can kind of just ease people's mind a little bit. So thank you so much for sharing that. Um, I do have another question for you. How can patients find resources or support to overcome barriers to trial participation, like transportation, costs, language barriers, etc.?
I think, well, I'll start with language. I think language is pretty solvable because most institutions have language lines. So, even if you're just coming in for your visit and you have and speak a language, there's a language line that is there to help translate so that you can understand what's going on. Um, Many clinical trials have funds built within it to help to accommodate those barriers, to help cover the costs of additional tests, to help, in some cases, provide transportation. So I think the clinical trials have really gotten better at realizing, not everyone can just drive right up to their local cancer center or their doctor's office, that they may have to catch two buses and a train. And so, a lot of programs offer Uber, Lyft, and type of ride sharing to help get the patients there safely. And I'm starting to see that more and more in a lot of the clinical trials that are being performed. So I think that is great, and hopefully that helps and extends to patients who are not necessarily right in the city, but maybe they're right on the outskirts of the city, because many times that's where we find some of the more advanced tumors, and patients that don't have all of the resources as those in the inner city, and hopefully getting those patients into clinical trials so that we can know more about their tumors and how to better provide treatment.
Wonderful. Isn't Uber and Lyft like a game changer? I mean, it has really like, and it wasn't here like a few years ago. It has really changed the game for people. Thank you so much for sharing that. The next question I'm going to ask is for our angel advocates. What role can patient advocates play in helping reduce barriers and bias in clinical research? Kai, I'll pass this question over to you.
Yes, so I will say that I am very grateful that I have learned with Tigerlily how to take, my clinical trial and cancer research expertise and translate it into something that's very palatable for the community. So what we do as advocates is, so one, we review, sometimes we can help teams review or create their consent form for clinical trials to make sure that it is transparent and that it builds trust with the community with the way we talk about it. I'm working on one study where they were like, maybe we shouldn't say it's AI in the consent because then people will, they won't want to do it. And, I said what you should do first is explain what the tool is and then let them know that that is defined as AI. Because then that way they'll be like, oh, okay, it's not so scary as the term AI. Like when I hear AI, I think of all those movies. I think of the Terminator, I'm like, what do you mean, right? So, one, to make sure that information that is out there for the community is easy to digest and that it is something that can be understood, to make sure that clinicians understand how they can do better sometimes. I think Tigerlily has an I am included framework where it kind of educates clinicians on how to better approach the community. We also, on the back end where I'm creating diagnostics, what I do is I also sometimes try to make sure that they look at diverse populations in those trials, like just try to increase our efforts to bring diverse samples into what we do so that we're sure that our tests are applicable to a broader population than what's easily available. Because as I focused my studies and my master's on inequities in precision medicine, it all comes down to access and participation. So, just always making clinical trials something that is more make it less scary for our community, right? Hold people's hands when they ask for that. I have a few patients I work with. They're just like, I don't know what to do. I don't know how to navigate this. Like, girl, just send me a text when you have a question. We'll have a phone call together. Building that community and encouraging more and more advocates to support patients in that way as well.
And Kai, if I can add on to that, I think also we need to make it more accessible to more physicians in the community. I think we look at clinical trials are often offered at the big universities, which is great. They do great work, but there are many of us who are in the community. And I mean, I have an investigator and have done research off and on throughout my career, but there are a lot of my community colleagues who don't. And so I think if we could make research accessible to them, get them the training that they need, so then they could actually be an ally to the larger institutions and helping to funnel, because usually if those patients have that conversation with their local provider, it'll make it an easier conversation once they get to maybe the larger institution where the clinical trial is held. So I think it's a two-prong approach. The patients, certainly, but also looking at clinicians and looking at different clinicians, maybe looking at primary care, OBGYNs, and getting them involved in the process. So it truly is a community effort.
Thank you so much. I want to just quickly, since you talked about that, Dr. Hampton, someone in the chat said, is it possible to start including a cultural sensitivity portion as part of medical training? I know that you personally can't answer that question, but you kind of touched on that, how important it is to get physicians involved and healthcare providers involved and trained, because it does take training. If you're not from a particular cultural background, it can be hard. That can pose as a barrier when trying to allow your patients to get access to certain treatments, certain trials. So that is very, very important. Um, I'm gonna ask one more question. This is kind of following up on what we were just talking about, Dr. Hampton. How do you work to overcome bias and ensure all patients receive the best treatment options?
Yeah, I think a lot of it just comes from really listening and understanding and sometimes asking a question, and understanding, and just saying, hey, I'm not really familiar. Is this, you know, something that you do in your community? Can you explain to me? I think a lot of clinicians are a little afraid to be that vulnerable. But people really like to share about their culture and their experience. And if we come at it from a way of like, I want to help you and I want to do something that's not disrespectful. I want to honor you where you come from, some of the traditions in your culture, which may not be, known to the American culture, I think can be a start, and realize we're not always going to get it right, but that's okay. I think just asking the question and trying to be as vulnerable as possible, which again, I know can be hard for a lot of clinicians. But I think also from the patient standpoint, don't be afraid to share that, hey, doing this type of treatment is something that is frowned upon in my community. How can I navigate that? How can you help me? And yeah, I think it just starts there with vulnerability on both sides.
That is so good. That makes me think about like alternative medicines and how people sometimes want to go that route as opposed to traditional medicine. And I think some doctors are becoming more hip to it, and they're allowing patients to kind of incorporate, supplements and things like that, things that are safe, of course. But it's just things like that, breaking down those barriers and actually seeing your patient as a person, as opposed to seeing them as, just another patient with a diagnosis, and getting to know them like on a friendlier level. It helps them open up more, and you're able to better treat them. You know what I mean? And kind of,
Absolutely.
work together and.
And I think sometimes as a physician, and what I've just sort of learned in sort of my journey is sometimes I have to let the patient do it their way, even though I know it's not going to work, but say, okay, let's try this for 30 days. Like I had a patient who said she was going to do some peroxide concoction. Okay, let's agree you're going to try it for 30 days. Let's meet back, have a conversation, do some other testing. It wasn't working. She and I had a conversation, and then she committed to the treatment that she needed to have. But it was because I allowed her to do that versus, and I know a lot of physicians are like, but we know it's not going to work. Yeah, we know, but sometimes you have to give that power to the patient. Sometimes that's an important part of the patient journey that I think many times as clinicians we're so quick to shut that door.
Oh, that's so good. Oh my
I want to
goodness.
thank Dr. Hampton for that. Thank you
Yes.
for collaborating with your patients in their care like that. That's amazing.
Well, I also look at it as, if I don't collaborate with them, do I want this woman to just go through the world and never get treatment? We all know how that would end. But, the fact that I could just develop this trust. And so, I just think it's important, so important to do.
Yes. Does anyone else want to weigh in on that? No.
I had a quick comment about the clinical trial, little history, and I'm taking off my Minorini hat and putting on my industry hat. So it's very complex. There's historical atrocities that have led to lingering distrust. uh, there's not enough representation in healthcare situations. People maybe are going to trust somebody that is from their community, that looks like them. Let's be honest. And then beyond that, again, historically, they're also, despite good intentions in this case, clinical trials have been focused, as we've already mentioned, on these large institutions that not everybody can get to. They're states away, or maybe, it's on the other side of the city. And so, again, when I'm thinking about those early stages, clinical trial development, again, it's one thing to have good intentions and say we want a diverse population. It's a completely different thing to execute it. And that's why these conversations are so important. I've learned so much in writing up clinical trial design, being a part of that process and saying, hey, if we want to achieve that, we need to go into the community. We need a leader, a trusted leader in that community. I've even, this is not my own personal experience, but I've even had a thought leader that said we're going to set up at the church because people are there every week. And then it's not a separate trip. So it's having these conversations, these very intentional conversations, being open about where we've been, where we are, and where we need to go. I think that's one of the most important things. And there was a question about clinical trials and whether or not doctors know about clinical trials. And one thing that I'll mention is certainly ask your doctor if they are participating in clinical trials. And if that's something you're interested in, encourage them to look at future opportunities. One of the potentially limiting things is that not every clinical trial is open to every doctor or every institution. So again, a doctor might know about many, many clinical trials, but again, if somebody like myself from industry did not go to their hospital system, did not go to their community hospital and partner with them first in the development, then they're actually not allowed to participate. So it's not that they don't know, it's just that they haven't gone through the contracting, the process, all things that are put in place to ultimately protect the patient, but also do limit access to those trials. So again, being your own self-advocate, as I've seen mentioned several times, and telling your physician, I want to go somewhere where there's clinical trial involvement. How can we bring that here? I think is very powerful.
Thank you so much, Michael. Yeah, that's very important. And like you said, or like Dr. Hampton said earlier, just kind of leveraging your connections as a physician. You know what I mean? Just, you may not be able to access those clinical trials, but there may be someone close by at another health institution or something like that, that you can kind of leverage relationships there. I would like to, at this time, kind of open up the discussion for our audience. If anyone has any questions for any of our panelists, please feel free to drop your questions in the chat. And I will just kind of try to keep my eye on the chat, but I would also like to just give some special thank yous. I would like to thank Minorini Silicon Biosystems for sponsoring today's program. To learn more about CTC testing, please visit yourcancercounts.com. I would also like to thank our lovely, lovely panelists today, Dr. Hampton, Kai, Megan, Michael. Thank you all so much for sharing your expertise and your experiences. It is so, so important. A few key takeaways. Biomarkers in clinical trials can provide valuable insight into treatment options. Patient experiences matter in guiding care. So please ask questions. Ask, ask, ask. It's always empowering. I want to encourage you to continue these conversations with your family, your healthcare providers, and your communities, and to connect one-on-one with clinic partners for more personalized guidance. I also want to invite you all to stay connected with Tigerlily Foundation and all of our panelists through their social media handles. We will drop that information in the chat. And if you're interested in joining the angel advocacy community, please email us at info@tigerlilyfoundation.org. And finally, I would like to encourage you to explore Tigerlily's biomarker and clinical trials resources so that you can stay informed, empowered as you navigate your journey. We do not have any questions at the moment, so I will go ahead and close out. Oh, wait, hold on one second. We got a question. This question is from Michael. If a doctor has not ordered a cell search test before, how can the patient help the oncologist to get the test ordered?
Great question. So it does have to be ordered through a physician, as was just mentioned. So if there is an interest, then going to the yourcancercounts.com or using the email address that was provided on that slide, the physician can reach out and request to have an account set up, which would result in them getting sent the materials they need. So, any of the tubes needed for the blood collection, the test requisition forms. So that would be, I think, the most the quickest way would be to send an email to the that was listed on the slide. So when that happens, the clinician would be connected with one of the sales leaders in that region, who would coordinate the setup and all the logistics. That would just have to be done the first time. After that, they can keep kits on hand and all the materials on hand.
Wonderful. Thank you so much for answering that. I'm getting my camera ready so I could take a picture of the the panelists' information. Thank you all so much. You guys have been amazing, simply amazing. Thank you for the work that you do. Again, thank you, Minarini, for sponsoring this conversation. Thank you, Tigerlily, for bringing us all together to share this space with one another. I am always, always excited to learn from advocates, providers, patients. It's just a wonderful, I'm sorry. It's just a wonderful experience. Thank you all so much. Have a wonderful weekend. Stay warm if you're by me. Bye, everyone. Thank you.